Okay, I think we're ready to roll here. Good morning, everyone, and welcome to the Compass Hin June office hours. This month's topic is going to be workplace violence. My name is Sean Laffey. I am the program specialist for the Compass Hin team. And again, thank you for joining us today. All right. Just a few housekeeping items. If you can, within the chat box, please just type the name of your facility, who you're representing. And also just remember to take a moment to double check that your lines are muted and to not place this on hold in order to avoid any on hold music that might be playing on the recording here as well. As I said, today we're recovering workplace violence, and also we are fortunate to be joined by Corinne Peek-Asa of the University of Iowa. Corinne is currently the Associate Dean of Research at the College of Public Health, a professor in the Department of Occupational and Environmental Health, and is also the Director of the Injury Prevention Research Center. And with that, I can turn it over to you, Corinne. Are you available to speak with us right now?
Oh, yes, absolutely. Thanks very much, Sean. So I'm happy to talk about the area of workplace violence. I've worked in this area for almost 25 years. And one thing I like about workplace violence prevention programs is that the interventions, they tend to be good for the workplace. They tend to improve the environment. They tend to improve the work culture. So that's, I think, a nice thing, that you can do an intervention that actually has some bigger impact on the workplace. So can we go to the next slide, Sean? So all of you are pretty well aware that workplace violence is very prevalent in the healthcare setting, and it may be one of the most common settings to experience this. So looking at the National Crime Victimization Survey, which is a national weighted sample of crime victimizations that includes questions about whether or not it happened in the course of work, we estimate about 900,000 violent victimizations in the healthcare industry. The highest proportion are usually among nurses, but it's interesting that we see reports of violence with every type of occupation. So sometimes like food service people, facilities people, it's really something that we need to think about as a workplace issue rather than a single occupation issue. Next slide. Thank you. So as we look over time, what we've seen is that we do see some increases, and this is looking at data from OSHA recordable events, which are a very different source than a survey, because one of the things that's interesting, especially in healthcare, is that very few of the violent events, especially threats, things that aren't physical violence but are threats or problem behaviors, are not reported. And I think one of the reasons they haven't been reported traditionally is that there hasn't tended to be a lot of change. And in fact, hopefully not as much currently, but definitely in the past, before workplace violence was recognized as an important healthcare issue, often I think there was retribution for reporting experiences of violence because you were seen as a troublemaker on the floor. But I think the culture around workplace violence and workplace violence has changed, and we have some evidence for that we'll talk about a little bit. But today we're going to talk a little bit about general prevention programs and what goes into a comprehensive structure, and focus mostly on de-escalation verbal techniques. Okay, next slide, Sean. So again, healthcare provider reports are very uncommonly reported. I think also thinking about physical assaults, and especially we've done some work in nursing homes and healthcare, even hospice facilities, home care settings. In the caregiving profession, often the patients are not completely aware of what they're doing. There may be patients that are under substances, that have psychiatric disorders, that have dementia, or something affecting their cognitive abilities. So they're not necessarily aware or intentionally creating a physical assault, and yet they're still committing that act. And even when the patient is not making a choice, but rather lashing out in a way without good judgment, there are still ways to think about prevention and creating cultures and environments that make those types of assaults less likely. So next slide, please. In thinking about the types of threat, One of the things that was really helpful when I was in California and I started doing my workplace violence work with Cal OSHA was looking at some way to sort of differentiate types of violence. And so I know there are efforts to update this typology, but this is one that's been used for quite a while and is helpful in thinking about how to focus interventions and how to think about different profiles of risk in different workplaces. So this typology looks at workplace violence based on the relationship of who's committing that violence, what in this slide is called the perpetrator, but I know especially in healthcare, you don't always think of the assailant as a perpetrator because sometimes, they're your patient who you're caring for and care about. So in the first type, the person committing the violent act is committing the business with an intent to commit a criminal act. Sometimes this is a robbery. When we look at homicides in the workplace, especially in the retail and service setting, this is the most common type of homicide. In hospitals, sometimes we see that as a patient or family member that's not happy with their care and they leave and they come back. And when they come back, the intent is solely to perpetrate a crime against the healthcare facility. In the second type, the person committing the violence is a customer, client, patient, or inmate. So this is, of course, the most common type of what we see in hospitals. This is also a common type of violence that we see in schools, in prisons, in facilities, any time that you are helping high-risk clientele. In the third type, the perpetrator is an employee or a past employee. And this is the type that gets most of the press, the disgruntled worker. It is a common shooter scenario when we see those, but most of this employee or past employee violence is much more related to bullying in the workplace, psychological harassment, which is very important because of how that impacts the work unit and the work culture. And then finally, in the last type, the person committing the violence is a personal acquaintance of the victim and doesn't have a legitimate relationship with the business. And this is important for healthcare because one of the most common scenarios is when there is a violent relationship and the perpetrator of something like domestic violence knows that one place the victim can be found is at the workplace. So seeing domestic violence, stalking, spill over into the workplace is really quite common, and some of the strategies for addressing that are a little different. They're a little outside of what we sometimes think about in occupational safety because the perpetrator, again, doesn't have a business relationship, but because of the detrimental effects they have on the workplace, it really is important to include these personal acquaintance risks in a portfolio of comprehensive prevention. But when we look at healthcare facilities, the most common typologies that we see are violence by customers, clients, patients, usually patients or their families, and then also worker on worker. So next slide, please. So I've pulled out in the next slide, this took just a couple minutes to find press clippings within the last not long period of every type of violence occurring across the world in healthcare. So we have something from Texas focused on an armed robbery in a healthcare facility, a health and wellness center. That would be a type 1 event where the intent is to perpetrate a crime against the business. In New Zealand. We see a type 3 event when there's bullying in the workplace. In the one on the right, in China, we see patient violence. And then at the very bottom, in Sydney, Australia, we see a stabbing based on an intimate partner relationship. So all of these are found in healthcare, and all of these are prevalent throughout the world in healthcare. So next slide, please. So this case was a landmark case in 1990. What happened is that a patient died in the emergency room. The father of that patient felt that care had not been adequate and came back to the emergency department with a firearm and opened fire, killing 2 people and injuring 2 people. And for some reason, this event resonated. One reason might have been that one of the injured patients, Frederick Maurer, was a patient, and a relative of the patient with Frederick at the time was an attorney, so decided to become an advocate on this issue. So although things had been moving forward with the California Nurses Association to address workplace violence, this case really bolted things forward, leading to the enactment of the California Hospital Security Act, which I think I summarize a little bit on the next page. But it was also interesting that, so next slide please, that the director of the hospital came out with a quote that further perpetuated the feel of the California Nurses Association that they really needed to advocate for something to happen, because the executive director of the hospital was quoted as saying there's really nothing that could be done to prevent this, short of locking down the emergency room and placing armed guards with metal detectors. And the irony here is that there are many things that could and should have been done before this event happened to prevent this event from happening. There were many moments when this could have been de-escalated, when a secure environment, a crime prevention environment could have prevented this from happening. So I think that the very public statement that these events can't be prevented was something that provided further fuel to create some advocacy. Next slide, please. So again, it was this event that led to the California Hospital Security Act, which was the first statewide legislation that required acute care facilities to implement a comprehensive workplace violence prevention program. And we worked with the National Institute for Occupational Safety and Health to evaluate this law and its components, and found that it was really successful. We focused on psychiatric units, so inpatient psychiatric units and emergency departments, and found that initiating the elements of the act really did lead to a reduction in all types of workplace violence. So let's now focus on what are the components of a comprehensive program. Next slide, please, Sean. So there are a number of different ways to structure a comprehensive program. Some of the most important things that aren't on the checklist are leadership buy-in and having a champion. And when we were evaluating the California Hospital Security Act, the hospitals that benefited the most were those that had one or more active champions, and that in their work role, they decided to take on and champion and foster and speak up and get workplace violence prevention programs on the radar screen of people who could actually implement and foster those in. Now, the champions didn't always have positions of authority. Sometimes they were nurse managers, sometimes they were nurses but not nurse managers, and sometimes it would be someone who had an experience and just felt the desire to speak up. So I think we need to study a lot more about how to foster and support champions, but it definitely was something that was important. But generally, the comprehensive elements involve some sort of threat team or committee. So someone has to be charged with staying on top of the program, modifying the program as things move forward. There's a number of things that can be done in environmental control, and the first line of defense are things like lighting and visibility, creating what's called a low-risk zone or work unit, and all of this is based on a concept called crime prevention through environmental design that can be applied in workplaces, it can be applied in public spaces. It's the notion of building a space where the propensity to commit a crime or be violent is reduced. Then after that is when things like bullet-resistant enclosures, security screens, things like that come into play. And in high-risk environments, some of that really rigorous security equipment is really needed. But it's important to do a thorough assessment to determine what are the right pieces of environmental control. Now, a hazard assessment is understanding what are the local risks. Are there dark corners? How are the drug cabinets regulated? Are there areas where it's really easy to isolate a healthcare provider and so they could become overtaken and assaulted? So that is best done in a participatory way where people who work on the unit get to talk about where do they feel unsafe and why is that and what can we do about it. So policies and procedures are important. They're important in the prevention arena, not just, there should be policies that help with the prevention upstream that then go all the way through the spectrum of what does happen if there's an active shooter situation. There's a lot of focus right now on active shooter training, and I wish there was a little more focus on how do we not have the active shooter when also recognizing we need to know what to do in all situations. So I'm going to skip to say that surveillance and reporting procedures are really important. And one of the things we found in looking at hospitals is that there tend to be a lot of overlapping systems, none of which are comprehensive. So it's not uncommon for security to have their own reporting, and that'll collect a certain type of things. The employee-on-employee type events end up in personnel files, but they're also not really recorded or used as data very successfully. Often there will be all of the OSHA compliance reporting, but it often doesn't have enough detail, so nurse managers will keep their own system of what's going on. So I'm just curious if this notion of kind of scattered reporting, not having one centralized decision-making database is something you guys experience in your settings. And I don't want to take a lot of time because I want to move into the employee training, but I do want to be a little bit interactive. So I think I can set up a poll. Oh no, there's a poll that has already been set up by Sean. So maybe just think to yourself, if you think the data that's being collected is able to be used in an easy, visible way to help you make decisions about security and workplace violence. So moving on from that, let's talk about de-escalation, because that is what Sean asked me to focus on. I'm going to spend maybe 10 minutes on this, mostly leaving you with some resources, and then have some time for some chatting. So next slide, please. So again, looking at a lot of hospitals, what we found is that not even every hospital has training in workplace violence prevention. And what we found is that we didn't find a single hospital that had training for all employees. So some of the employees, like intake registers or facilities or food services, are excluded from the training, even though they're often the ones to walk in aggressive situations. So it is important that everyone knows their role in the violence prevention policy and procedure, even if it's to recognize and just bring in someone else if they're not the right ones to handle it. So next slide, please. So training should include a lot of pieces. And one of the challenges that we've seen is there are a lot of prepackaged programs that teach some of these skills. And hospitals will rely on those prepackaged programs without adding a component that is specific to that local hospital. And I'm sure you are all very aware that when you've seen one hospital, you've seen one hospital. And within a hospital, when you've seen one unit, you've seen one unit. There's just a lot of difference in the types of patients, the type of communication strategies, the type of procedures that are done, the way doctors round through, the way nurse structures are. So given all that diversity, it's really important to think about the local environment as well as some of the more global parts of training. Next slide, please. So there are a lot of cues that can be looked at to see if someone might be becoming anxious. There are verbal cues that certainly involve threatening behavior, but sometimes even a change, like if someone starts to get really quiet, that can also be important. Situational cues, so patients who are in pain, who are feeling like they're not being treated fairly, and the importance there is it's their perception of how they're being treated, which is independent of how they are actually being treated. So they may be perceiving something that is standard of care, but they might act violently or aggressively if their perception is that they're not being treated well. So sometimes it's important, we'll get a little bit to this later, it's their perceptions, not necessarily what the reality of their situation is. And then there are also a lot of nonverbal or behavioral cues. But the most important piece, I think, is that none of these cues are very predictive when you look at them together. And there's this notion of sort of instinct, and you just sort of sense that it's going on. I think it's hard to rely on that, because think about how busy you are. And assessing the status of your patient from a satisfaction, violence perspective is often not part of the scanning that you're doing as a healthcare provider. So I think it's important to build de-escalation into the way you deal with patients all the time. So let's go to the next slide and talk a little bit about what some of those components are. So the most important thing is that in de-escalation, the conflict is never about you, even though most likely you are going to be blamed directly for it. So depersonalizing is one of the most important parts, and that is hard to do as a healthcare provider because you are in a caring profession. What you're doing because you're trying to help. But even if you have every right to be angry at how the patient is treating you, expressing that anger will not help diffuse the situation. If you are not able to repress that anger, and of course that is a very unhuman, hard thing to do, it's important that hospital cultures really allow you, and it be completely okay to turn that over to someone else and to say, I am very sorry, I can't help you at this moment, but it's very important to me that someone takes care of your needs, and I'm going to go get someone right now, and that someone who's maybe a little removed can come in. So again, it's important to focus on the person and their perspective, and sometimes their perspective will not be accurate. They might not have the cognitive ability to read the situation, or they might have perceived something they've been told or something that's happened in a way that they don't understand the process of what's going on. And I think that this is complicated by the fact that in general, we don't have a population that is highly literate about how healthcare works and operates. Okay, so to the next slide. Once you're able to sort of assume a position that it's not about you, how do you find out what that patient's perspective is? Getting them to talk, to tell you what they're feeling, even if you can't fix it, is really important. And it's important to do that in a non-judgmental way. So some of the ways to do this come from motivational interviewing, which most of you are probably familiar with in treating things like new chronic diseases or substance use. But they work really well for de-escalation as well. So asking open-ended questions, and sometimes questions alone can feel threatening. And I know when I talk to my kids, for example, I might ask them a question and I can't keep the sarcasm out of my voice. So why do you want to stay out till midnight? So sometimes a statement is much less threatening and easier to depersonalize. So tell me what is happening. Give me an update on what's happened so far. Those sometimes are a really good way to ask an open-ended, to solicit some open-ended input. Affirming and reflecting on what you hear so the person feels listened to. Sometimes that is the most important first step, and they know they're not happy about what's going on, but just the fact that someone has listened to them can de-escalate very much. So I understand you are feeling angry. I understand you've waited a long time. And then listen openly. Their perspective is their perspective, regardless of your assessment of it. And again, that's part of the depersonalizing. Summarizing what you've heard, so again, the patient feels listened to, and expressing concern even if you can't solve the problem. And again, bring in others as needed. So next slide, please. You have just a couple more slides. So some of the verbal skills, these are just some talking cues that I don't think we have to go through all of them, but sometimes even on a little card, it's helpful to keep some of these, how do you start an open-ended question? What are some of the reflections that you can say? So things like, I understand. Please tell me what's happened. Those kinds of things can help when you're, feeling like what you really want to do is react to the patient, just using some of the talking cues. Next slide, please. Also, there are a lot of good nonverbal cues. So keeping yourself acting calm, breathing slowly, focusing on the person. So despite the fact that there are 8 million things going on and you do not have time to deal with this patient, focusing on them at that moment can be really helpful. Not staring at them, moving slowly, not touching them, and then avoiding your own aggressive or actions that can seem aggressive or that just make you non-verbally remove yourself from the conversation can also be helpful in the de-escalation process. Next slide, please. The last piece I want to leave you with is that the National Institute for Occupational Safety and Health has an online workplace violence prevention program for nurses. And it goes into many of the different types of components of prevention programs. So it talks a bit about de-escalation, including some of this material, but also some of the things related to environment and things like that. And we are now working on a new module for standalone healthcare facilities, which I think might be really helpful for rural clinics where there's not, or even smaller hospitals where you're not sort of part of this huge behemoth organization that has 15, armed security guards at every moment. So I'm happy to let Sean know when that comes out. And then the last slide is the link for this. But if you search NIOSH Nurses Workplace Violence Training, you will get the link to the training program. So with that, I am happy to answer questions now. If anyone wants to follow up with questions later or by email, I'm happy to do that as well.
Feel free to put any questions into the chat, and I can actually unmute everyone right now if you had any questions at this time.
So let me ask a question that I think is a really important skill. Has anyone actually been in the heat of the moment and be able to redirect your conversation, sort of putting on that, I'm in a conflict, but my job is to de-escalate. Has anyone ever been able to sort of switch themselves in the middle of that growing escalation? And then my question is, how did you do that?
Oh, well, that's pretty fancy. What should help with
The chat is saying it's learned behavior, absolutely. Okay, someone who works in corrections. Yeah, you get a lot of that. It's a very tough environment.
Here it doesn't say anything about it. Turbo light tower, black nylon carrying case, remote controller in case, extension cord, protective UV glasses.
I think we might be hearing some things that are
My piece, so yes.
related, not a question. So I'm also curious, you know, I've been in Iowa a while, but I haven't done healthcare violence work in Iowa. I've worked with like, local companies and things more in the private industry and then also in government organizations. So I'm curious, maybe people could write some things down in their chats, especially from, I see someone from DeWitt, so from the smaller communities where the healthcare facility is such an important nexus of the community. What are some of the things you see as being a little bit different? I can imagine the fact that you maybe know people a little better would be a positive in maybe there being a little less violence. Any other things anyone wants to share about what might be sort of special about your environment? So where does a violent act against an institution fall? So someone who is angry with a system based on their own ideology, but not a result with affiliation. This to me would be someone who is like angry at the institution and comes in to do a violent act would be a perpetrator of a crime against the institution. So it's really the relationship with the business, because even if you feel like you've been treated badly by one doctor, you're really mad at the whole hospital. So that would be considered, the aggression might start with them being a patient or a family of a patient, but when they're actually coming onto the premises because of an ideological desire to commit a crime, that would be in the type 1. So here's another hospital that's done ALICE training, and there's a lot of ALICE training, and it's very helpful training. I really wish it, though, also included prevention elements, because again, it's not the full spectrum. Rural hospitals I work with indicate the community looks out for one another. The see something, say something thinking is already there in small town hospitals. Yes, absolutely. And I think that really does help reduce violence in rural hospitals. It makes me really want to do a study to look at different types and numbers of violence in different types of healthcare settings. One thing that is interesting about rural environments, and this sort of came out, we just finished doing a study focused on suicides among farmers. And it was such an interesting conflict in what we found talking to some of the farming families, that it is such an important piece of being a farmer that you are there for your neighbor. You'll drop everything to help your neighbor, but at the same time, it doesn't mean you would ask your neighbor for help, especially if the help you need is related to something psychological, depression, or feeling like your farm operation is not doing well, or anxiety about that. So I do think that conflict might exist in healthcare in rural areas where people are very independent, very proud, they're connected with the community, but they might not be comfortable asking for certain types of health. So again, that notion of approaching things with open-ended questions. I mean, you're here today because you have, a broken arm from your auger, but let's talk about how tell me how you're feeling more generally. Was this in somehow related to anxiety or something like that on the farm? So these are great things that people have shared.
All right, I'm not seeing any more questions. Oh, hold on, maybe one more. Yep, there was one more here, so I don't know if you see that.
Okay, yeah, so the SAFE training, that's one of the, commonly used sort of de-escalation, but also just sort of holistic patient engagement types of trainings. And it's good to hear that it was mandatory. And it's good that it also includes patients and others, because often there's so much focus on the patient, and sometimes, especially in rural areas, patients are kind of far away from their families, so strain on what that means for the family. And it's not necessarily the job of the healthcare industry to take care of that, but recognizing that that stress exists can be very helpful. And it sounds like you guys are already thinking about that. Okay, well, Sean, I know that we are a little after time. If anyone wants to follow up, I'd be happy to respond to emails. And thank you for letting me speak with you today.
Thank you, Corinne. Absolutely. I particularly like the option, not the option, the importance of building de-escalation into the components of how you interact and work daily in a healthcare setting. And always to, of course, remember to focus on the person or persons and their perspective in the situation and how to appropriately respond to that as well. And again, if you want to make sure you look for this violence training from the National Institute of Occupational Safety and Health, I can also post this on Innovation for everyone to have easy access for as well. I do see a few more chat questions coming in here. They're just thank yous. But I'm going to move quickly into some Compass HIN updates for everyone, and just make sure everyone's up to date on what's coming out here. So for upcoming events, our Opioid Guardianship Take 2 project review will actually be tomorrow, June 21st. Coming up later this week is our introductory informational webinar to Detect Falls. And also closing up next week will be our Readmissions Refuel project review. Next month, office hours will be Wednesday, July 25th. And just keep an eye on your calendar for down the road. The September Hand Learning Community will be Tuesday, September 25th. Always just remember to check out HIN newsletters and always look at Innovation for other events that are upcoming, and you can always register as well. In addition, there have been some questions from HIN hospitals on the new sepsis recommendations, and Compass HIN is working to address this. There is an event tentatively set for August on sepsis, so please watch for Innovation and newsletters communications, as there will be more to come on this event and topic, and I, of course, want to share this with everyone as well. With that, I'd like to thank everyone, and of course, thank Corinne for coming today and speaking on behalf of Workplace Violence, and I hope you all have a great day.